Good morning, everyone. So, today I will be talking about infection control in dentistry. Okay, there is in dental practice not long ago, blood stain swab after tooth extraction was simply thrown in trash without thought, not anymore. After the emergence of antibiotics during the World War II, the industrial world lost its age-old concerns about the infectious disease. The period-ended infectious disease are still with us. Of course, it took a jolt from the HIV epidemic to force improvement in the management of dental office environment. Although some dentistry regulations as just another bureaucratic burden, the uprise of the COVID-19 virus in 2019 has made proper management and infection control of the dental office environment to become an unavoidable part of running dental practice. The basic considerations, okay? The basic considerations cross infections, that is, transmission of infectious agents between patients and staffs within a clinic environment. And of course, the chain of infection. This include the pathogen, the source, the mode, entry, and a susceptible host. And then again the source with the patients with overt informations, that is informations that is clearly shown when patients in prodromal stage, healthy carriers of the pathogens, that is very convalescent or asymptomatic. Mode of transmission include direct contact of tissues with secretion of blood, droplets containing infectious agents, contaminated sharps, and other instruments that have been improperly sterilized. Basic considerations: mode of entry, direct or indirect, inhalation, inoculation, ingestion, or transplantal. And again, some of the major pathogens and their transmission route are shown here. Some of the blood-borne pathogens examples are HIV, HBV, HCV, Treponema pallidum, herpes virus, mycobacterium tuberculosis. Oral and respiratory diseases, oral diseases, and human herpes virus types 1 and 2, oral candidiasis, oral syphilis, and gonorrhea, herpangenia, systemic diseases like oral lesions, etc. Oral and respiratory diseases include respiratory diseases like streptococcal pharyngitis, tuberculosis, and streptococcus pneumoniae. We'll just talk a bit about COVID-19 as well, because it was considered a very relevant and the recent one of the most infectious disease caused by the severe acute respiratory syndrome, coronavirus 2 or SARS-CoV-2. Disease was first identified in December 2019 in Wuhan, and it said spread globally and became in a coronavirus pandemic. Common symptoms include fever, cough, shortness of breath. Other symptoms may include fatigue, muscle pain, diarrhea, sore throat, loss of smell, and abdominal pain. So when can we suspect COVID-19? All symptomatic who have taken international travel last 14 days, symptomatic contacts, laboratory informed cases, all hospitalized with severe acute respiratory illness, and symptomatic refer of fever, cough, shortness of breath, etc. Now we will come to the rationale for infection control. The logic for routinely practicing infection control is to break the chain of infection. In our Kerala government also was promoting the slogan "break the chain." It is because if we are breaking the chain of infection, then we are more safe. So a total of his pathways of cross contamination is patient to dental team to patient, patient to patient, dental office to community, and from community to patient. Recommendations and regulations include Centers for Disease Control and Prevention, American ADA, and Organization of Safety and Aseptic Procedures, regulations by the state and local regulations, Food and Drug Administration, and Occupational Safety Health Administration. The practical features which can be used, that is personal hygiene, of course, the clinic clothing, barrier protection, and immunization. What includes the personal hygiene, that's rigidly followed code of hygiene, refrain from touching anything not required for a particular procedure. That include covers, cuts, bruises with dressings. Hair should be kept short or tied up. Hand care. Hand care is your meticulous, dedicated sink for hand washing. And from this COVID 19 itself, we understood the importance of hand washing. And these are the areas which are most frequently missed that are marked as red, and less frequency missed as marked as blue, and the other not missed areas. Before patient contact, after contact with anything contaminated between contact with different patients during patient care, before and after invasive procedure, before and after contact with wound, between glove changes, immediately if skin is contaminated or injury occurs. Some of the hand washing technique, the procedures you already know about. Hand hygiene agents that are used include alcohol, chloroxidine, 2 to 4%, iodophos, phenolics, triclosan, quaternary ammonium compounds. Efficacy of hand hygiene preparations in killing bacteria. Now, the clinic clothing, of course, is freshly laundered uniform or garment should be changed at least daily as soon as visibly contaminated. To improve cross-infection control, dental surgeons need to improve the frequency of changing into a clean set of clinic clothing. Involves use of protective barriers like gloves, eye shields, face masks, rubber dam isolation, also referred as PPE or personal protective equipment. Gloves, that's disposable latex or vinyl gloves, to establish reasonable standards of hygiene in order to safeguard both dental personnel and patient. Eye shields, of course, types include goggles, glasses without shield or face shield. Face masks, that is types paper, glass fiber, polypropylene. Effective lifetime is 30 to 60 minutes only. Then again, rubber dam isolation, and something which is used well, and it's very important abroad, but in the Indian scenario, rubber dam isolation is not much used. But it has to be used in operative procedures to minimize saliva. Saliva contamination is one of the major reasons that restorations doesn't last enough. And blood contaminated aerosol production. Clear visual field minimizes instrument contact with the mucosa, reduces aerosol formation. Chloroxidine gluconate mouthwash prior to treatment and intraoral microbial load decreases. This shows some of the dental devices and procedures known to produce airborne contamination. Ultrasonic and sonic will consider the greatest source of aerosol contamination. Use of high volumic evacuator will reduce the airborne contamination by more than 95%. Then again, air polishing, air water syringe, tooth preparation with air turbine handpiece, and tooth preparation with air abrasion. Some of methods of reducing airborne contamination, including PPE like barrier protections, pre-procedure rinse with antiseptic mouthwash such as chlorhexidine, high volume evacuator, as we told earlier, 95% of the aerosol is removed by high volume evacuator, and high efficiency particulate air room filters and ultraviolet treatment of ventilation system. The order of putting on barriers, that is include first you have to do protective clothing, then the protective eyewear, then the mask, then the gloves. Then removing barriers include disposable gown, gloves, protective eyewear, and mask. As you can see the sequence here for putting on protective personal equipment. So the immunization schedule is another must needed and often ignored conditions of infection control. That is hepatitis B virus recombinant vaccine, 2 doses intramuscular, 4 weeks apart, third dose 6 months after the second. Indications: pre-exposed process for those risk of exposure to blood and body fluids. And again, immunization shall be scheduled for dental health personnel. Hepatitis B immunoglobulin 0.06 milliliter per kilogram intramuscular as soon as possible after exposure. A second dose should be administered 1 month later. Of course, indication is post-exposure prophylaxis. These are some of the important aspects of infection control. The next part is sterilization that we'll discuss in the next session. Thank you.